Hi, this is Elliot Fishman, and welcome to our latest talk. And this is going to be the role of AI in the detection and management of pancreatic cancer. And a lot of what I'm going to discuss is things that we are doing at Hopkins, things that we're doing internally, things that we're doing with Microsoft, and things that we are doing thanks to the Lustgarten Foundation. So let me get started. One thing we have to look at, and this is really our hope, 40% of pancreatic tumors smaller than 2 cm are missed at abdominal CT. They're missed at a time when they're diagnosable. They're missed at a time when patients may be resectable for cure. If we only could drop this number significantly, we're going to make major changes in the outcome for a disease where at best 12% survival at 5 years. And that's improved from 7% from a few years back, but 12% is still as bad as it can get. In this article by Toshima, the patients that have early pancreatic cancer are shown to have certain signs that predict subsequent PDAC development, including atrophy, faint enhancement, main pancreatic duct change, which means enlargement, and looking at these features can allow us to make an earlier diagnosis again when things are curable. And in this article, they talked about clinical stage 1 pancreatic adenocarcinoma with these findings: focal atrophy, again, faint enhancement, MPD changes. You could think about this and look 4.6 to 1.1 years. We always think about pancreatic cancer as being diagnosed too late. Here, this article is telling us that perhaps it's not that we're having a disease that's diagnosed too late, is that we're not diagnosing it early enough. There's an excellent article coming out in Abdominal Imaging by Satomi Kawamoto speaking about some of the early findings and some of the misdiagnoses we see and how we can improve on that to really improve patient care. This article by Toshima, again, making the point that if we think about these things, perhaps we can decrease the morbidity of this disease and improve prognosis. So again, this is very hopeful. So as we think about detection of disease with AI, the things we've been learning the last couple of years are indeed very promising. Obviously, ideally, you would love a blood test where patients could be screened, something along the realm of perhaps for colon with Cologuard, something like that. Well, we don't have anything like that yet, and surely we would love to come up with a drug which will treat pancreatic cancer when it's detected and cure the patients. But again, lots of work being done, but we're nowhere near making that diagnosis. So let's look at CT. It's been around now 53 years since Hounsfield's first images in 1971. If you look at how we read a CT scan when I started, we looked at 8x10 film, 4 images, 30 to 40 slices per case. Acquisition time approached 50 minutes or so. 10-second scans. We had a fast scanner, but it took a minute to reconstruct. Limited resolution. A small tumor might be considered something 3 or 4 centimeters. Not now when we think about it under a centimeter. Today, we don't look at film. Most people don't know what film is. We've gone from 20 or 30 or 40 slices to 4,000 or more slices per case. The acquisition time is typically under 10 seconds. Reconstruction is real time, basically. High spatial resolution, but still, that's not been good enough. Now, the challenge is what we do in CT, or what we do in many parts of imaging, it's kind of like Where's Waldo? There's a lot of information in the image, and we're trying to find something, in this case, Waldo. When you see it, it's great, but you could spend a lot of time not seeing Waldo. And many times, it's not that we're saying rule out pancreatic cancer. If someone says rule out pancreatic cancer, perhaps you'll pay more attention to the pancreas. But if it's just vague abdominal pain or a little bit of back pain or just vague anything, yes, you're looking at the pancreas, but perhaps not as carefully as you could because you have many cases to read and you need to look at the pancreas, the liver, the kidneys. You need to look at the spleen, the bowel. There are many things we need to look at. So it's really this combination of looking at many things that becomes a challenge to us. So we think about where we stand. Typically, axial CT, we talked a lot about using multiplanar routinely, coronal and sagittal, and many people do that now. We talk about the value of volume rendering and MIP imaging. Despite many excellent articles and the clinicians wanting it, it's rarely done. We've written a bunch about cinematic rendering now, and I'll show you that. We're looking at radiomics, and we'll show you that, and more deep learning beyond just radiomics. So at the end of the day, there's three things we've always done. There's three things we need to do. And I think these latter three things will change the curve and surely bend the curve in favor of the patient. Now, volume rendering, that's the Pixar guys, right? Drebin, Carpenter, Hanrahan. And then we did work on that for many years. Volume rendering, state of the art. Crowey's a number of years back, as NVIDIA developed faster and faster chips, decided that we could volume render, but do it better because we can use different lighting models. And so he wrote an article talking about this basic infinite lighting model with shadowing. And shadowing is what helps make things stand out. Also, it's basically texture mapping. So we're looking at more subtleties. And Siemens took that work and came up with cinematic rendering, which we've been working on for the past 7 or 8 years. We've developed trapezoids. Well, trapezoids is how you look at the information. And what we've done is create presets to make our work faster, where I could do most cases in well under 5 minutes. But it's the presets, and I have probably 20 presets for the pancreas, depending on what I'm looking for, depending on the size of the patient, depending on the injection rate, and many other factors. But we're able to look at, so for example, in this case, you can see a 1 centimeter vascular lesion in the head of the pancreas, which is a neuroendocrine tumor, easy to see on the coronal views as well, near the GDA. You can see small vascular lesions in the liver, which means this patient also had liver mets, though they are very tiny, a good reason to look at MIP imaging. And on venous phase imaging, the lesion is less well defined, but it's still easy to recognize. When you look at the cinematic rendering, you see the dilated pancreatic duct. As I change the texture maps, you see the GDA. You also see the patient's tumor right there and there. And as I go into the data set, take away a lot of the other information, showing you now the celiac with GDA, hepatic artery, the SMA with its branches, and showing you the tumor standing out. One of the key things we're trying to do is create images where the pathology stands out. We've done work with AI for detecting neuroendocrine tumors, and the accuracy of AI is in the high 90%, 20% better than radiologists, particularly for smaller tumors. And again, here's just some more images showing that. You can see certain things to also understand that cinematic rendering would be ideal for detecting these tumors, but also for staging, preoperative planning. We've also published a recent article that shows when you have neuroendocrine tumors or potential neuroendocrine tumors by tail of pancreas, and your question is this a neuroendocrine tumor or a splenule, looking at the texture maps can help you make that decision. So very important. And again, changing the parameters allow us to see things differently. Here I'm bringing back a lot of the texture of the pancreatic gland, but the tumor is very nicely defined on the cinematic rendered. And here's some coarse rendering looking at boundaries of the pancreas, showing you very nicely the head of the pancreas, but also nicely showing you that patient's neuroendocrine tumor. Now, another example, looking for an incidental, this was incidental, but looking for abdominal pain. Do you see anything in the pancreas? Is there a little dot in the pancreatic head, perhaps? Well, what about right here in the body? Look at this little dot here. That's about 3 millimeters. And yes, once you know it's there, you can show it better. And in this case, interestingly, the neuroendocrine tumors showed better on venous than arterial phase imaging. And there it is very nicely on the coronal views along a center line. And here it is very nicely on the cinematic. And you could see on the cinematic, look how much bigger the lesion looks and how much more obvious the lesion is to see. And as you go to the next set of images, here it is again. So you can see that, yes, I did find the lesion on the regular CT after I knew it was there, perhaps. But look how much more obvious things are on the cinematic rendered image. Moving along to pancreatic adenocarcinoma, which is our topic of choice today, look at this lesion that was missed in the head of the pancreas. A little over a centimeter. Yes, I know you should see it. SMA, SMV, this is arterial phase. There's a hypodense lesion, but those are the things that are routinely missed. You can look, the portal vein and SMV look good, and yes, you should see the lesion, though it's better seen on volume rendering, and it's surely better seen with texture mapping on cinematic rendering right there. And again, on the coronal views, it's particularly well seen. Again, it's a good example of showing you how much easier it is to see. Now, what we need to have is the computer generate the correct cinematic rendered images without you doing any work, and then finding these lesions. And putting that under the realm of AI is where we want to be. Or in this case, this dilated pancreatic duct, atrophy of the gland, textural changes, and right here, there's a mass causing that obstruction. Remember, we speak if you see a dilated pancreatic duct, there has to be a reason. You can see it better on the volume rendered views, and on the cinematic views, nicely seeing the tumor, atrophy of the gland, dilated pancreatic duct, showing all of those features very nicely. Interface of normal pancreas to tumor, interface of pancreas to duodenum, or in this case, a tumor at the junction of body and tail of pancreas, pancreatic duct dilatation and abrupt cutoff, which tells you there's a tumor present, but that's one of the most common things that missed. Here it is with classic volume rendering. There's the tumor, there's the dilated duct. And here again, cinematic rendering showing you the tumor, the dilated duct, and glandular atrophy. As you go further and look at these images, you really begin to understand how good we can do with texture mapping. In many ways, it's similar to radiomics because you're changing the texture of the tissue, or the tissue with texture is different with normal versus abnormal tissue. There's a range of variations. Now, the challenge with cinematic rendering is, particularly you see when people try to do it and they are unsuccessful, you have an infinite number of parameters you can change and create an infinite number of images. How do you pick the best image that shows the pathology? Another example, textural changes, body of pancreas extending toward tail, nicely shown on the cinematic rendering with mild dilatation of the pancreatic duct, again showing you a carcinoma of the patient's body of the pancreas, very nicely shown. We also can stage the patient, the celiac and SMA, very nicely shown there. And then in this case, atrophy of the distal gland, dilated pancreatic duct. Could it be chronic pancreatitis? I don't know. But as you look more carefully, this duct dilatation and abrupt cutoff have to bother you. You have to be suspicious that there's a mass here. If you don't believe there's a mass, that's great, but do EUS to prove there's not a mass there. Here it is on the cinematic, the textural change, the duct, the abrupt cutoff, all very nicely shown, and the textural change in the body of the pancreas by tumor, comparing that to the head of the pancreas where the texture is different. Again, a really nice example of a under 2 centimeter pancreatic cancer obstructing the duct, causing glandular atrophy, and a potentially resectable lesion, very nicely shown. And you can see I can change the parameters. Here I'm making a set with, I'm able to look inside the heart, but this also accentuates the normal gland. but the abnormal gland is better seen. Compare normal versus abnormal. Again, lots of the possibilities we have with cinematic rendering. We also wonder whether it's now the new Apple device or the HoloLens we've worked on, looking and being able to create 3D maps, tumor, vessels, planning, the interactivity. Can we use this type of information to even do better? It makes great images. We'll have to see how it works out. Okay, let's look at radiomics. Radiomics refers to the extraction of mineable, high-dimensional data from radiology images. What you're really doing is looking more carefully at the ones and zeros in the image. With radiomics, we're looking for things that we may not see. The premise is that imaging data conveys meaningful information about tumor biology, behavior, and pathophysiology, and may reveal information that's otherwise not apparent. If you look at it, radiomics has been used in the pancreas now, and I'll show you some examples for lesion detection, predicting response to chemotherapy or radiation therapy, predicting long-term response, predicting patients for surgery, many different things. In this article by Schur, speaking about radiomics in general and oncology, talking about image preparation, we need to segment the image, and then we need to look for feature extraction. There are many different features, thousands and thousands of features. The key is to figure out which ones are important and then use that to build a model to help you detect what you're looking for. So they talk about first order and image texture and image filters. Typically, we start with 5,000 or 10,000 parameters, get it down to 50, and then get it down to under 10. When you think about it with radiomics, what you're really saying is tumors are spatially heterogeneous structures. Heterogeneity can be quantified. Radiomics converts this imaging data into high-dimensional mineable feature space. We're trying to learn what the images are saying. And again, first-order statistics, distribution of individual voxel values, histogram, mean, median, maximum, minimum, things like entropy, skewness, kurtosis are all things we think about. And you can create all of these different maps and figure out which ones are important for the job you're trying to do. You could look at shape, compactness, maximum 3D diameter, sphericity, surface area, and the like. Again, trying again to pull information from that pancreas and that data set. And then, of course, second-order statistics, texture features, whether it's statistical interrelationships between voxels, gray level co-occurrence matrix, gray level run length matrix, are all things that can be used. And then, of course, a range of different filters and different wavelets to try to really accentuate normal from abnormal. The issue is, how do we do this, and how do we do it on a reliable basis? One of the challenges with radiomics, it's very dependent on the scanner, the scan protocol. So if you do it at Hopkins with a certain injection rate on a certain scanner, then you take data from a different hospital with a different injection rate and different scanner, the radiomics features may not be transferable. That indeed is a challenge. And then what we try to do and what we've done is be able to create a signature. This is work we did looking at radiomics features and then comparing adenocarcinoma versus normals, recognizing they have different signatures, looking at 40 features, and then when you get down to it, your accuracy, 99%, sensitivity, 100%, really impressive numbers, at least in that data set. Now, of course, in a typical real-world experience, you're not going to have 50% of the data with cancer and 50% normal. Typically, if you have 1,000 patients, you should show one pancreatic cancer. The more pancreatic cancers you show, that's not really reality, and it makes the thing look better than it is. But again, this is very promising results. CT features of PDAC can be subtle, And using radiomics, we can do this better. In this article by Chu, the results were indeed very, very promising. Now, what else can we look at? We could look at other applications in pancreas. We could look at some of the work done for detection, as I just showed you, classification of tumors into different grades, and prognosis of what we can look at. And let's do this. Let's take a few-minute break and come back and look at some of the features we can see with radiomics, and then look a bit more at some of the other advances in AI. See you then. If you like this video, make sure to subscribe to the CTisus YouTube channel. You can also visit us at ctisus.com for even more videos, plus quizzes, pearls, protocols, and oh so much more. We're also in the App Store and have well over a dozen apps for iPhone and iPad, all completely free. Thanks for watching.